Hello and welcome to the May 22nd installment of APHA's 15 on COVID-19 series. I'm your host, Dan Zlott, Vice President of Education here at APHA. Today, we're going to be talking about something that has been in the news a ton this week, and that would be hydroxychloroquine prophylaxis. You have probably seen all kinds of news stories about this, thanks to an interesting mix of politics and science. So let's go ahead and jump right in and see what there is to learn. As usual, I have nothing to disclose. Here are your learning objectives for today's episode. All right, well, so let's start off by understanding the backstory and sort of what has kicked off this renewed interest in hydroxychloroquine all of a sudden. So this started when earlier this week, the president announced that he'd been taking hydroxychloroquine as prophylaxis against COVID-19. And so politics being politics, that immediately kicked off a firestorm of all kinds of interesting responses, commentary, speculation, and even quite a bit of name calling, both for and against the idea of using hydroxychloroquine as prophylaxis for COVID-19. So that really is, at least for this week, what has spawned this renewed interest in hydroxychloroquine and COVID-19. Now, rest assured, the United States is not alone in drama related to COVID-19. So let's take a look at maybe some other drama around the world. So even before the president made his announcement about the hydroxychloroquine that he was taking, other governments actually had recommendations related to the use of hydroxychloroquine for prophylaxis. I've highlighted the Indian Council of Medical Research, but there are plenty of other governments out there. And so, for example, the Indian Council of Medical Research recommends hydroxychloroquine as prophylaxis for healthcare workers as well as for asymptomatic household contacts of confirmed cases. And so even there's drama, international drama, and we're seeing this play out in well-respected journals. So in this instance, we've got a couple of different letters of correspondence to Lancet Lancet Infectious Disease. And so we've got one letter saying, hey, the Indian Council of Medical Research is being irresponsible by making this recommendation. We've got another correspondence responding to the first correspondence saying there's really no data and we need to do something to stop the spread of this, and hydroxychloroquine is relatively safe. There's data about potential efficacy for the treatment of COVID-19, and so it's certainly better than nothing. So, as I said, rest assured, the United States is not alone in the drama related to hydroxychloroquine prophylaxis for COVID-19. All right, well, now that we've got the backstory, let's start taking a look at the data. So where did this whole idea of hydroxychloroquine for COVID-19 prophylaxis start? Well, a lot of it came from early reports out of China and almost in incidental comments in the introduction to papers or in the first little bit of papers before you get into the methods and some of the details. There were almost passing comments made that patients who are taking hydroxychloroquine for other reasons, most commonly autoimmune disorders, but for other things like malaria prophylaxis, were seen to be protected from actually contracting COVID-19. And so many of these reports or comments are based on survey data, observational data. They're not robust clinical trials. They're not formal retrospective looks at data or anything like that. They're just sort of, hey, in my experience, it seems like patients who are on hydroxychloroquine for other reasons don't seem to contract COVID-19. So that's kind of maybe where a lot of this started. So in contrast to that, other people who had patients who were taking hydroxychloroquine for autoimmune disorders started to publish case reports saying, no, that's not true. Patients on hydroxychloroquine can in fact get COVID-19. So here's one case that we've chosen as an example. 39-year-old female with rheumatoid arthritis taking 200 milligrams of hydroxychloroquine a day who developed symptoms consistent with COVID-19, and she tested positive for COVID-19 about 24 hours after her symptom onset. And she went home for about a week, and she continued to have fever, mild cough, muscle pain, fatigue for about a week. And then she went to the hospital because her symptoms weren't resolving. And so she was in the hospital for 48 hours, and then she got discharged because her symptoms had resolved. And the hospital did really nothing special. They continued her on her hydroxychloroquine and gave her no other COVID-19 directed therapies. So this is a case that suggests maybe that A, she had a mild case of COVID-19, but B, that patients on hydroxychloroquine can in fact contract COVID-19. So what other literature or what other data is available? And it turns out, in general, with COVID-19, the amount of literature available has just exploded. It's unreal. So there are a huge number of articles out there that consist almost entirely of speculation, hypotheses, and some interesting things, basically calling for additional studies because the data that's out there is so poor and people are throwing out all this speculation, and people are saying enough of the speculation. Can we please just have trials? Let's just report on trials. And then other people are saying, yeah, we agree. Here's some great trial designs that we think would be great to help answer questions. And so there's very little literature of relevance out there. It's all speculatory or proposal. So it's been an interesting experience digging through the literature. So the real question is are there actually any trials, case reports, et cetera, that help us answer the question about the utility of hydroxychloroquine for COVID-19 prophylaxis? And the answer is yes, there is. So there is one study that I was able to find. It's an open label, non-randomized, non-controlled trial. And so it consists of a situation where a social worker who worked at a long-term care hospital developed COVID-19 or was diagnosed with COVID-19, and she was working for 2 days prior to her diagnosis. And so she had a significant amount of exposure to staff and patients. So she had symptoms consisting of fever, muscle pain, malaise, headache, and cough for 3 days prior to her formal diagnosis, and 2 of those days she was in the hospital working. So this is every hospital's worst nightmare, obviously. We do know that the social worker wore a mask while she was walking in the corridors, but it's unclear if she wore a mask while she was in patient rooms. Now, in a couple of slides, we're going to talk about how they kind of stratified the risk of these patients, but all 193 inpatients were considered to be exposed to the index case or our social worker. And essentially, she visited every floor in the hospital, including the ICU. The graphic there kind of shows the path of her travels throughout the day, throughout the couple of days that she was there. And basically, you can see she visited everywhere in the hospital. The exposure was documented by video surveillance, at least in the corridors in terms of where she went. They were not able to document the interactions in patient rooms, so that's where they are unclear about exactly what types of interactions happen there. In addition, 24 of the 123 healthcare workers in the facility were considered to be exposed, and they were sent home to quarantine themselves for 14 days. The remainder of the healthcare workers continued to work, but they were quarantined in a hotel while not working. So there's sort of our exposure. And again, in a little bit, we're going to get into risk stratification of these exposures. Now, after they had the index case, the hospital then went and tested all the patients and all the healthcare workers for COVID-19. And there was a second healthcare worker who incidentally did not have any contact with the index case that she could remember, who tested positive for COVID-19. So this second case was an ICU worker who reported a headache while she was working in the ICU for a 6-hour shift. And the worker wore a mask the entire time she was working in the ICU. So that's sort of our second case. So those are the 2 cases that we know of in this hospital. So 14 healthcare workers were exposed to the second case, and as before, they were quarantined at home. The rest of the workers continued to come in and work. So the authors of the paper then attempted to stratify both patients and staff into risk levels based on the extent of their exposure. So here's what they found. 9 hospital staff members were classified as high-risk exposures because they'd either shared an office with the index case or had lunch with the index case. And so obviously if you have lunch, you have to take your mask off to eat, then that obviously might increase your risk significantly. 15 hospital staff who reported contact with the index case were considered to be intermediate risk, so they had some contact, but not as close a contact as the high-risk group. 69 patients were exposed to the index case or the second case were considered to be intermediate risk because they had either participated in a social program with the index case or been cared for by the second case who was working in the ICU. 14 healthcare workers who had contact with the second case, as we mentioned on the previous slide, were considered to be low risk, but they were also quarantined. So there were 206 individuals between healthcare workers and patients who could not be classified because the extent of their exposure to either the index or the second case really couldn't be confirmed. So there's our risk breakdown. Now, so what was the intervention that they used? Well, they used 400 milligrams of hydroxychloroquine once a day for 14 days as post-exposure prophylaxis. And that was given to 193 patients and 29 healthcare workers. Now, so we'll jump into some of the outcomes really quickly. We'll start off with some of the non-hydroxychloroquine related outcomes. The first one was that 2 patients died from causes other than COVID-19 and were excluded. And at the time of autopsy, they confirmed that these patients were COVID-19 negative. So they were able to confirm that they died of causes other than COVID-19. So they were excluded from the study. 2 patients refused hydroxychloroquine, so they were excluded from the study. And additionally, 6 healthcare workers quit their work and were excluded. And it's unclear what they meant by quit their work, whether they just took some time off or if they said, enough of this healthcare business, I'm done, not doing healthcare anymore, and I'll find something else. Unclear what that meant. And then 1 healthcare worker disagreed with post-exposure prophylaxis and was excluded. And so again, it's unclear what's meant by that, whether they just didn't agree with the concept of post-exposure prophylaxis or if they meant that the patient or the healthcare worker had maybe prior exposure to hydroxychloroquine and had adverse events that disagreed with them. So it's a little unclear as to what they meant by disagreed with post-exposure prophylaxis. So regardless, that healthcare worker was excluded as well. So now let's talk a little bit about the population demographics. And this probably won't come as a surprise, but there were significant differences in age between the patients and the healthcare workers, as you might expect. In a long-term care facility, the patients tend to be a little bit older than the healthcare workers on average, and that's what we saw. Additionally, there were a higher proportion of females in the healthcare worker population as compared to the patient population. And finally, not surprisingly, there was a significant difference between the number of comorbidities that existed in the patient population as compared to the healthcare worker population. And again, this is a long-term care facility, and so almost 100% of patients had comorbidities. So the most common ones were dementia, hypertension, neurologic diseases, probably including stroke, Alzheimer's, Parkinson's, things of that nature, bone and joint diseases. And so that's sort of our patient population. Now, let's move on to talk about the COVID-19 outcome. So this is pretty interesting. So it turns out that aside from our index case and the second case, no patient or healthcare workers were found to be positive for COVID-19 over the course of the study. And the last point of PCR testing was performed 1 to 2 days before the end of the hydroxychloroquine regimen. So, yeah, that's interesting. It seems on the surface as if the hydroxychloroquine prophylaxis was effective in preventing the development of COVID-19. Now, the huge caveat to that, of course, is that we can't go back in time and see what would have happened if this same population had not been given hydroxychloroquine. Maybe we would have seen more COVID-19. Maybe we would have seen no change in the outcomes. So this is, of course, the problem with uncontrolled trials. It's a huge question mark. So they did also report on some of the safety outcomes, and here's what they found. More than 95% of both patients and healthcare staff who started the post-exposure prophylaxis completed the regimen. So it was pretty well tolerated. Just under 16% of patients and healthcare workers reported 1 or more symptoms during the post-exposure prophylaxis. And the most common symptoms were diarrhea, skin rash, GI upset, and bradycardia. So diarrhea and skin rash, GI upset are all pretty well described with hydroxychloroquine. Bradycardia, of course, is a concern. Anything that prolongs QT intervals can potentially have impact on heart rhythm. So we saw a little bit of that here. And so the hydroxychloroquine actually needed to be discontinued in 5 patients, and that was again due to similar reasons: GI upset in 2 patients, bradycardia in 2 patients, and inability to fast in 1 patient. And that's a little bit unusual. I'm not sure where that comes from. Hydroxychloroquine is not necessarily administered in a fasting state. In fact, it's recommended that you give it with food or a meal. So why that was an issue for the patient is a little bit unclear, and the authors didn't really go into that. So, but those are our patients who ended up having discontinuations of the medication. So what were some of the limitations of this study? Well, first off, it's an open-label, non-randomized, non-controlled trial. As we discussed, that's obviously a huge impact for us. We can't go back and assess what would have happened if the healthcare workers and patients had not gotten the hydroxychloroquine prophylaxis. So that would be phenomenal to be able to do that, because we could actually answer this question very positively. Unfortunately, we're not in that situation. There were also a number of other interventions that were implemented to minimize risk, and that included quarantining of staff. They mentioned that they transferred some patients to other hospitals, and then, of course, the staff were wearing masks. So it's very difficult to truly assess the effectiveness of the post-exposure prophylaxis as compared to some of these other measures that were taken by the hospital. As I mentioned, the index case and the second case were wearing masks. So again, depending on how effective the masks are at preventing the transmission of COVID-19, that may have an impact as well on our ability to assess the effectiveness of hydroxychloroquine for prophylaxis. And so one other potential limitation, and it's sort of a double-edged sword, and you'll see what I mean, but if we believe, and the data does show that hydroxychloroquine does inhibit viral replication, at least in the lab, if that's true, this could decrease viral loads below the limit of detection on a PCR assay. So we might have essentially, quote unquote, false negatives on the PCR assay. At the same time, the reason I call it a double-edged sword, if it's suppressing viral loads that effectively, that's exactly what we want it to do. And in that case, it may not necessarily be a, quote, false negative. It might just be a true negative. It may be a prevented case of COVID-19. It's an unknown. We don't have the answer to that. And so it's another potential confounder there. So those are some of the biggest limitations of this particular study. All right, so we've reached that point in our 15 on 19 episode today where it's time to talk about the bottom line. So as we have seen so frequently, available data are currently quite limited, both in terms of quantity as well as quality. Data that's available comes from open label, non-randomized, uncontrolled trials, comes from observational surveys, and it comes from case reports. So as mentioned, it's impossible to go back and see what would happen if hydroxychloroquine had not been given to some of these patients and see what the outcomes would have been. So really, we're left with a big question mark. Additionally, data are conflicting. So there's some data that says that there's benefit to hydroxychloroquine for prophylaxis. There are case studies that say that nope, even while you're on hydroxychloroquine, you can still contract COVID-19. So again, really more of a question mark than an answer. So as has become our theme on COVID-19, the bottom line is that more data are required to assess the efficacy of hydroxychloroquine as a prophylactic measure against COVID-19. So with that, that will wrap up today's 15 on 19 episode. Thank you so much for joining us. On Monday, June 1st, we are going to explore another hydroxychloroquine related topic in case we haven't had enough of those. There has been a huge paper that came out. You may have heard about it in the news as well, talking about some of the increased risks that are associated with hydroxychloroquine and the lack of efficacy. So we'll dig into that paper and see what there is to learn from it. And we hope to see you on Monday. As always, if you have questions about COVID-19, please keep them coming our way. covided@aphanet.org is the email address there. We review those multiple times a day, and we really appreciate all the ideas and suggestions we've gotten. So thank you to all of those who have submitted questions and continue to submit questions. We look forward to helping answer those questions. So with that, we will wrap up, and we hope to see you on Monday.